The way we take care of ourselves is ever evolving.
And what we know for sure is that our mind and spirit are linked to our physical body.
And that our wellness seems to extend into our communities and the planet we all share.
It is very, very clear that wellness is interconnected.
We love spending time with you to explore and practice the breakthroughs, the insights, and the passions of incredible people helping us all see the world in a whole new light.
This is Health Gig.
When you think of menopause, you don't usually think of an orthopedic surgeon, but our guest today, Dr. Vonda Wright, is a practicing board-certified orthopedic sports surgeon, author, speaker, researcher, and innovator, serving as a key opinion leader at the intersection of musculoskeletal aging and longevity, women's health, and sports performance. She's back again on Health Gig. Welcome, Dr. Wright.
Thank you.
We're so excited to talk to you because there's so many important topics to cover, but we want to start with a little bit about you, maybe where you're from and how you got started as an orthopedic surgeon.
Wow, that's great. So I was born in Chicago when my parents were grad students, but pertinent to this story, I was then moved to a farm in Kansas where I learned all kinds of amazing things. And it's an amazing way of life to raise kids in the country. What a benefit. So I learned to do a lot of things with my hands. And so as time progressed, my first career actually was as a cancer nurse at the Rush Cancer Institute in Chicago. And I have a master's degree in nursing. But what that did for me, I was at the bedside, I was teaching at the university. But what that did for me between about 23 and 28 was, amongst other things, was it really framed my life and helped me have a lens for what I think is important and how I think people should be treated. Even though I ultimately decided to go back to medical school and in that process chose to harness the capacity of my hands to take care of athletes and active people of all ages and skill levels, what I bring to my orthopedics from being a bedside cancer nurse is the treatment of people as whole people. Nobody is ever in need to me, or nobody is ever just a frozen shoulder to me. And so what I have found is that people really crave being treated as a whole person and not a body part. And I think that's something that's really, the national zeitgeist is changing. I don't think people are going to accept being treated as a body part. But right now, that's actually the way medicine is set up in silos. So the more we can integrate, not integrate in the sense of alternative medicine, but integrate the cardiologist talking to the orthopedic surgeon, talking to the women's health expert. In fact, I think everybody should be a man's health expert and a woman's health expert because health is from the top of your head to the bottom of your toes.
Yeah. So what's really fascinating, and thank you for telling us your background, because that is incredible to have grown up in Kansas on the farm. I imagine you did learn so much in a different frame of mind. But what's so amazing about what you're talking about these days is women's health as it relates to hormones, as it relates to the pains I'm having in my joints and in my body and this and this. And that's like eye-opening for women, right? Like what's happening? Why all of a sudden am I getting frozen shoulder? Why does my knee? Why do I have plantar fasciitis? That's why we're excited about the work you're doing.
Yeah, thank you.
And please, we want to talk all about that and how you are blending the discussion of women's health with our bones and our muscular body.
Yes.
So thank you for that. So fill us in.
So you know what? I see patients every Mondays and Thursdays, and today, this is what happens. Women like you and me and women like our younger daughters, they come in and we start talking about the thing that they've put on the, how can I help you today? What is your chief complaint? But ultimately, women say this to me. They say, doc, I don't know what's happening. I just feel like I'm falling apart. And, sometimes I talk to my other doctors, my family, and I think I'm going crazy because they tell me nothing's wrong with me. And after I hear that, when I first started down this road, if every single woman is saying that to me, unsolicited, they're all coming to the same conclusion that I think I'm falling apart. And I'm really well read. I started putting it all together. And we have known for 30 years, ladies, that there is a relationship between the rapid advancement of arthritis and menopause. 30 years ago, way before I ever went back to school. I was never taught that. So, I started digging deep and read some of the original work on frozen shoulder done by my mentor, Joe Hannafin from Hospital for Special Surgery in 2011. She wrote a paper about the 4 stages of frozen shoulder. And at the end of the paper, it's called the discussion session. She's discussing this seems to happen to women in their 50s. As I put the pieces together, well, what happens to women in their 50s? Estrogen walks out the door, she slams the door behind her, and she never looks back. Could there be a relationship between my women feeling like they're falling apart, the rapid progression of arthritis that we've known for 30 years, and frozen shoulder that seems to happen to 50-year-old women? Holy cow, I'm smart, but it doesn't take a lot to put the pieces together. So as I dug deep, there are actually 6 things that I've included in a recent paper that we published called the Musculoskeletal Syndrome of Menopause. Now, here's the point of that paper. It's not the end-all be-all paper. It is only the beginning to give women and scientists a launching point to really understand the role of estrogen, testosterone, and progesterone on the musculoskeletal system. Estrogen affects inflammation in the body. We know that estrogen dampens down the release of inflammatory cytokines, which is a fancy word for chemicals. We know that it acts directly on the immune system through a complex molecule called the inflammasome to dampen down inflammation. Women commonly get frozen shoulder, which is an inflammatory process. People with uncontrolled diabetes get it too because it's an inflammatory problem. Women also have total body pain. The word for that is arthralgia. I think, and I've been saying this a lot publicly, I think a lot of fibromyalgia that is diagnosed as a garbage can diagnosis for women because we don't know what's wrong with them. They're tired, they're in pain, they do this. Maybe a lot of people with the diagnosis of exclusion fibromyalgia are really in perimenopause and their estrogen is left and their whole body hurts. So arthralgia and frozen shoulder, part of inflammation as a category of MSM, right? Number 2, we've already talked about the rapid progression of arthritis. Estrogen is critical for the maintenance of your collagen matrix, which is what arthritis is. It's just a padding of collagen matrix. Number 3, we know we lose muscle mass. Estrogen is critical for maintaining muscle. We know we lose bone density. And then finally, we know that our stem cells, our muscle-derived stem cells, which are now called satellite cells, lose their potency, their viability. Estrogen plays a huge role in that. So those are the things that we put together in this paper so that women could walk into their doctor's office and not say things like, I have a frozen shoulder, my body hurts, I'm losing my muscle mass, my knees hurt, because that's 6 things. And that makes in a 15-minute doctor's visit, right, which is all insurance will pay for, it makes doctors' heads spin. What they could do is they could walk in and say, I am in perimenopause. I am a midlife woman. I am postmenopausal. I think I have some of the musculoskeletal syndrome of menopause. And that frames it for everybody. It gives us a nomenclature. That was the whole point. And if it sparks controversy, perfect, because that's going to get enough press to change the world. If it sparks research, perfect. If it aids conversation, perfect. There is no wrong answer.
If we're in our 60s, have we missed the window for estrogen, or can you take estrogen anytime?
There are guidelines which say that optimally it should be started within the 10 years after your last period. That being said, in modern menopause care, we believe that every woman is a sentient being. Every woman should have her own risk factors assessed. So there may be some women in their 60s who have too many risk factors that it would make it not the best option. But there are many women in their 60s for whom it is still a viable option. I think making blanket statements about individual people with individual genetics is lazy. I think we live in a time of precision medicine. We sequenced the genome over a decade ago, so we now can prescribe health at a genomic level. I often, when I'm talking from a big stage, talk about in the 1900s when people died in their 40s. we slipped into then the next 100 or so years, which I call watch and waiting. It's what we grew up with, the medicine. It was generic, one size fits nobody. Most of the studies were done in men because of funding.
Yes.
But now we don't have to live that way. And so that's why I'm less hesitant to give you a blanket statement, because I believe that even in our 60s, we deserve a risk assessment.
That makes so much sense. And, those of us in our 60s, we were told for so long, don't do it. It's going to cause cancer because of the women's study, right?
Yeah,
Could
Women's
you
Health
share
Initiative.
a little bit about that and why that's a real big problem? We feel like, as Doro kind of indicated, we feel like, wait, what happened? Wait, we did what we were told. And now, so
Now
if you can
what?
share. Yeah, now what?
Yes. In 2002, there was a study published called the Women's Health Initiative. Many good things have come out of that huge database, but one of the sub-studies within that took a group of the mean age was 70-ish-year-old women and gave them oral estrogen replacement. The study was stopped early because what they found was in these populations of older women, they were in their 70s median age, there was thought to be increase in cardiovascular disease. So instead of doing what science normally does, which is reconvene the scientists and have a discussion about the relative merits of the data, somehow this study was leaked to the press, had a press release, had a press conference without the authors really having time to sift through the data. A blanket statement was made and estrogen was taken away from a generation of women, many of whom were already on it. What has happened in the intervening times? A few things. Most of the authors of that original paper have walked back the data. The paper has been largely walked back to say, you know what? That's not what the data showed. In fact, you may have had these people on your podcast. If not, I would suggest it. The world's data on hormone replacement has been collated by Avram Blooming, who is an oncologist, and Carol Tavares. She's a PhD researcher, and they have examined point by point, data by data, the role of estrogen and the research, and they have walked back all the absolute findings because for most women, the benefits of replacing hormones. Think about this. Many women in midlife have thyroid disease. We don't say, oh, I'm not giving you Synthroid. On any given day, men walk into my clinic getting testosterone replacement because they want to have more sex. Are you kidding me? And then we have an entire generation of baby booming women that have been caught in the middle. The baby booming women that I talk to are enraged.
Yes.
That they are caught in the middle.
We really
You're really enraged,
enraged.
right? Yes.
really enraged. And we feel alone. I mean,
Yes.
of course, there's the new movement that we've been part of and listening
Yes.
to, but there's that element of like, can we trust this?
Yeah,
Are
it's
you,
confusing.
can we really trust it this time? We're 60 and we really don't want to put ourselves at risk for cancer. And also the other thing, our doctors who are wonderful, they're not up on women's health.
No,
And
they're
so
not.
this information is not getting to them.
So I feel like there is no field, there is no fellowship on women's health past reproductive years. There are
Yes.
fertility fellowships, but there are no menopause fellowships. We are post-reproductive for 40 or 50 years of our lives. What the heck? I mean, I'm so glad I'm not reproductive anymore. Who wants that bother? But that doesn't mean I'm dead. Look at us. We're not dead.
It's so true.
Yes.
It's so true.
So doctors are not trained. And so if you go to a doctor who doesn't know, they just don't know. So all of us that do know are largely self-educated. But I feel like every doctor needs to know because women are 51% of the entire population are born with ovaries. We are a force not to be ignored.
And I liked what you said earlier, and I thought it was really important. I know when Dora and I first learned it, that almost all the studies were done on men, young men, right?
Young men.
In their 30s. And then even mice were men, male mice.
Oh, I
Up
know.
until
How about
like
that?
2016, 2017 or something. Now it's like, wait, what are we going to do? And what are they doing now, or what is happening?
Lots of things have happened. I mean, there's a self-anointed group of about 300 doctors who are screaming from the rooftops. And there are lots of other doctors interested in this, but trying to change the way women receive information, trying to educate in a research-based way. Try not to make one size fits all through guidelines that are meant for safety, but not for precision care. So there's that. What we're also doing, people like Jill Biden, Halle Berry, raising money for research. Listen, do you know why only men were studied? Do you know why male mice are studied? Because it's cheaper. Research is incredibly expensive. Listen, I've gotten a little bit political. If it was a bra burning situation, I might do it. But listen, if we want something, we're going to have to raise the money to do it ourselves. I frankly think if I put out and I might do this next year, put out a GoFundMe, I could get 1 million women to give $5 if it meant answers to the questions. I feel like women of means, if they want answers, they need to put their money where their mouth is, and let's set up a nonprofit that then funds research to answer these questions. Sometimes we just don't know. I've gotten some feedback about this paper I wrote, and I encourage that because it continues a conversation. But the reason we don't have what is the dose response we need to build better bones with estrogen? What is the dose response we need? What is the definitive randomized controlled trials? Ladies, it is because research is expensive, and the U.S. government and research labs have prioritized researching on males because it's cheaper, because we don't have to deal with the reproductive issues of whether a woman is pregnant during research or not. Listen, easy doesn't mean it's right. I know you have a very influential audience, and I hope they hear the passion in my voice to say, if you want something, we are not the victims of the passage of time. Put your money to it, put your influence to it. That is how we're going to change this, not merely observing that we've got work to do.
Right. When you talk about estrogen, there's 3 types, correct? And so often people talk about just estrogen as a whole, but our understanding is there's 3 types. Can you break it down?
The one we are most interested in replacing from a systemic level is estradiol. It is the most powerful, it is the most abundant, and it's the one that does the most work. So when we talk about estradiol replacement, it comes in pills, it comes in transdermal patches, it comes in 4 times compounded, it comes in pellets. Most of us do not recommend compounded because it's unregulated, pellets because once it's in there, you can't adjust the dose for 4 months. So we're left with oral and transdermal, and there are risks and benefits to both. So that's, again, each woman gets to have an assessment of what's going to work for her. So you've got estradiol systemically. I choose to take mine transdermally. I still have my uterus, so I must also have micronized progesterone so that the 2 are offset, so my endometrial lining of my uterus doesn't go unchecked. But that is not the whole story. We know that estrogen can be applied to the face. So now there are products, because we'll lose collagen in our face. It's part of the natural aging process. And so we can apply estrogen transdermally to the face. It's such a low dose that it doesn't get absorbed systemically. So it doesn't add to your patch. To prevent chronic UTIs, urinary tract infections, urosepsis, or lots and lots of pain in a genital area, vaginal estrogen can be applied as a cream no matter what your age is. No age limits on vaginal estrogen. But so many women become incontinent with age. So many women have chronic UTIs, therefore become antibiotic resistant, and so many women die of urosepsis. Why wouldn't we want to introduce them to vaginal estrogen, which is not absorbed systemically, does not cause blood clots, does not cause heart disease, but it can improve the quality of a life of a woman so much. My mother is 85 years old. I put her on vaginal estrogen because her skin was fragile. So for women in their 60s, I want to return to this question. Have you been left out? What can you do? I think there are a few pathways. You can do nothing. You're doing okay now. You can do nothing. I still take call. I'm a practicing orthopedic surgeon. I see frailty in women. I see women in their 70s and 80s falling, breaking a hip. 1 in 3 women who do that will end up in a nursing home, and that is not a future any one of the 3 of us would ever want. So that's what happens if you're going to do nothing, but that is a choice. It always is. The second choice you can make is go down the pathway of having a serious conversation with a menopause educated doctor. What are my risks? What are my benefits? Should I go down a hormone replacement mode? Whether you decide to do that or not, everybody has the opportunity to build a lifestyle which will make them physically and mentally resilient. So even if you have never lifted weights in your whole life, now is the time to start. We got to rebuild our muscle. Even if you already have osteoporosis because no one bothered to check for you, you can take the steps to maintain your bone. This, my friends, is a call to action. We're observing, okay, estrogen's going away. We've observed that. It demands a decision. Am I going to sit here and let time happen to me, or am I going to get in front of time to build a lifestyle that will make me unbreakable, which is the new word I'm using about building this lifestyle. You know, it goes with the fact that I'm an orthopedic surgeon.
Yes.
Yeah, right?
Which is so cool. I mean, that is so badass that you're like an orthopedic surgeon and you're talking to us about estrogen.
I am. Listen, bones are from the top of our heads to the bum of our toes. Why wouldn't an orthopedic surgeon be interested in the role of estrogen from the top of our heads to the bottom of our toes? Why not? Why? Listen, here in my office, look what I have. This is a model of a hip bone. You've probably never seen it. This is a femur. It's a model, people, not a real one. 1 in 2 women. So one of us, one of you, has the potential statistically to have an osteoporotic fracture. 50%, people. 50% of us. That is a big number. That's a shocking number. 70% of all hip fractures, about 30% of all people will break their hip right here at this neck. 70% of these happen in women. When this happens, 50% of the time, you will not return to pre-fall function, meaning look at your houses. You will not be able to return to live on your own. You will not be as independent. You will not say, I'm going to do what I want to do when I want to do it. 50%. 30% of us, my friends, will die. So let's put that 3 of us in a frame. If we all break their hips, one of us is dying. And I don't say these things out loud to be hysterical. I do not say these things to be fear-mongering. This is the fact of what we're facing now. So how do we get in front of our bones? Not only for ourselves, but for our younger daughters, for our granddaughters, because we lay down bone until we're 30. So when we're in our younger years, if we don't eat enough, if we don't exercise, if we have to take medications such as steroids, or we choose to smoke, those are all reasons not to lay down enough bone. But we start losing estrogen and testosterone, which are critical for bone health in our 40s, even before we even know that we're perimenopausal. Ladies, I have all the time really young women in their 30s and 40s who I do DEXA scans on. I do DEXA scans on everybody, and they're already osteopenic, which means low bone density. I had one that was frankly osteoporotic in her 30s because she never laid down enough bone. So I think every woman needs to open their eyes to the fact that the future for women is frailty unless you get in front of it, number one. How do you get in front of it? Let's get a DEXA scan. Insurance will not pay for it until you're 65. Okay, well then let's save up our Starbucks money, which can add up to $10 a day. You can get a DEXA scan for like $99 in most cities. If you just Google, they're popping up all over the place. So you know where you are. Number 2, again, I'm going to sound like a broken record. If you have never lifted weights in your life, now is the time. Strong muscles pull on bones and make them stronger. If you are not doing impact exercise, which is as simple as stomping around your house in a meaningful way. I get this question all the time. What if my knees hurt and I can't stomp around? Do you know what NASA does? When astronauts come back from the moon or the space station, we haven't been to the moon in a while, but the space station, they put them on trampolines, little rebounders, right? There's good data. You can stomp around in a pool if it hurts on ground, right? We just need a little impact. So those are 3 things. Number 4, we have to feed ourselves. Starvation leads to bad bones. We need 30 grams of protein at every meal, vitamin D with K2, and magnesium. You can get fancy and add selenium, boron, and 6 prunes a day if you want. And then I have all my women do this. I do 3 retreats a year called Midlife Mastery. And one of the things we teach people, in addition to weightlifting, in addition to what their bones are doing, I have my speed and agility coach, Coach B, teach women how to move their feet faster and how not to fall down. Because you can have bad bones, and if you never fall, you might be okay. But we are one fall away from tragedy. So now I teach all my women foot speed and agility. Because you know what I do? I have this big tote I carry around. I call it my V bag. I put it right by my desk. I don't know why I dump it there, but I come in, I sit down, I dump my bag, and then I rush out to see a patient, and I trip over my V bag.
Yes.
But I don't fall down because I have the foot speed and the balance to just hop over it.
That's
so
really
I teach
good.
all my women to be a little faster on their feet, to jump rope again, or to stamp around the house, not because you're mad, just because we need some bone bashing.
And even one thing, jumping up the steps, you know, like take your 2 feet and jump up to each step. I think we read that
That's
somewhere.
brave. Yeah, that's
very
brave.
And then works on, exactly. But
Hold
you're
on
right.
to the
just
rail when you do that, please. Yes.
Exactly.
Yeah.
Can we circle back to the weight training?
Yeah.
How heavy should the weights be?
I love that question, and I get it every single day. Again, this is a precision answer because what's heavy for me might not be heavy for you. But here's how you measure. Number one, if you've never lifted weights, now is the time to invest in a few lessons from a trainer, right? You would never drive a car without a few lessons. So we need to understand how our body works, what the right form is. Now's the time. There are lots of great apps right now that can teach you that at a very democratized, affordable way. So that's number one. We got to learn. Number two, heavy means what you can lift 4 to 5 times. So women over time have been taught to pick up the mamby-pamby pink weight and do it 30 times because God knows we don't want to build muscle. That's exactly what we want to do.
Yeah.
And then they're like, oh, I don't want to get big. I'm sorry. It takes years of hard work to get big. You are not going to get big. You know what you're going to do? You're going to get strong and you're going to get lean. Do you know what muscle is? Muscle is nature's Spanx.
Yes.
It's not that I don't love me some Sarah Blakely. I love that woman's initiative, but I'd rather have muscle as nature's Spanx than several layers of constrictive garments. So
That's good.
As a surgeon, when you go and you look at, say, knees, I know that so many of us have knee problems. Is that, Dora, maybe you could ask this question.
Yeah, can you just talk about meniscus tears? Because
I care.
nobody quite knows what to do, whether to have surgery, and sometimes people have surgery and it doesn't work.
Oh, I'm going to clear it up for you.
Good.
First, what is the meniscus? I would go get a knee model, but then I'd have to get up. So it's your leg bones, your femur, which is your thigh bone, and your tibia, which is your shin bone, come together like this. But bones are actually pretty fragile. Our body has to pad them from each other. We do that first with the cartilage, that is the end plate of the bone, which itself is fragile. And then we do that in a second layer of protection with the meniscus. Meniscus are shaped like this. The one on the inside looks like a C, the one on the outside looks like a circle, and they are made out of a type of collagen to pad your bones. They absorb 80% of the weight of our body. We get one set from birth to death. And so with time, we can tear it, and many of us do. So when you have a meniscus tear, it is often in midlife and beyond accompanied by some early arthritis or significant arthritis. If your pain is aching, swelling, stiffness, those are the words that describe arthritis. If your pain is sharp, stabbing, intermittent, those are the mechanical words. I like to do this for my patients because it helps them. Oh, there's a mechanical component. Those are the words attributed to a meniscus. You can have a meniscus tear that really doesn't do this to you. So when I recommend treatment pathways, again, there's always the chance to do nothing. Everybody goes to physical therapy to get strong, butt, core, hip strength to support our knees. Strength will help get out of knee pain. If your pain is just aching, we're going to treat you more for your cartilage support. I do that by getting strong. I rarely give steroid injections, rarely, unless someone comes in screaming pain. I do a lot of something called platelet-rich plasma, which takes your own growth factors out of your blood, injects it into your knees, and people can get tremendous support from the anti-inflammatory effects, sometimes lasting years. That's why I use it. There is good data now, and I do this here in my clinic, for using adipose matrix, which is a little liposuction. We clean it up and we put it in our knees. That can last a couple years using fat stem cells and the matrix it lives in. The time to go to surgery for a meniscus tear is this. It is when the sharp, stabbing, intermittent pain, this pain, is the predominant symptom. Because doing arthroscopy, which I do through needles now, I don't make incisions at all. We have technology that we can put needles into your knee and take out the meniscus because it's like a camera on a wire. Arthrex makes this. So the recovery is remarkable and fast and no general anesthesia. The time to do a needle scope is if you have mechanical pain, sharp stabbing, intermittent popping, clicking, catching. If you do an arthroscopy for aching pain, we've known for a long time arthroscopy does not help arthritis. It helps the mechanical pain. So that's how I want you to think about what are my symptoms like. Just having a meniscus tear, unless you're a 20-year-old athlete, does not mandate surgery.
The arthritis
Yes.
that's in there,
Yeah.
what do you do about that?
So I treat arthritis in a programmatic way. Arthritis can have a range. We score it from 0 to 4. 0 is no arthritis. 4 is bone-on-bone arthritis. Consider a knee replacement. In between, there's a lot we can do. These are going to sound familiar. Number 1, anti-inflammatory diet. We must stop eating added sugar, processed foods. They're hugely inflammatory and they make you hurt more. Number 2, we must get stronger. Our muscles act as shock absorbers. We don't want our bones bashing together. I'm hitting my hand for those of you listening. Bashing together. We want them compressing. We do that with our muscles. I send every patient with arthritis to physical therapy to get them started. And when they're done, we transition them to the gym. Staying strong is a lifelong endeavor. Number 3, it matters how much muscle we have because our knees bear 10 times body weight. So if we're carrying 100 pounds of extra adipose tissue, it is not cushioning your body, it is bashing your knees. So I don't like to tell people to lose weight. I like to tell people to recompose their body. We're going to trade fat for muscle because you may end up weighing more. When I am full of muscle, I weigh more than when I was never full of fat because I've always been an athlete. But you can be skinny fat, meaning you don't weigh much, but you have a high body fat percentage. I want you to be full of muscle and therefore unload your joints. And then finally, there's the medical interventions. We can do anti-inflammatories. We can very rarely, if you're in screaming pain, put in a steroid injection, which on average lasts 2 weeks. We can use platelet-rich plasma, which harnesses your body's anti-inflammatory power. And then in my clinic, we also use adipose stem cell matrix to prolong the need for a joint replacement. And I call this approach to how I manage as a sports doctor, I'm a sports orthopod, joint longevity, because I am trying to never hand you over to a total joint replacement surgeon. And most of my patients would rather not have a total joint. But here's my philosophy on that. If you get to the point where your knees are so painful that you're starting to give up what you love, you're no longer going out with your friends, you're not playing sports, you don't want to walk around in the sunshine, I would rather give you a total joint and give you 20 years of your life back than sentence you to sitting around disabled from the pain of your knees. And so in doing that, I'm going to help you choose the very best total joint surgeon I know. People with really good outcomes that treat their patients like human beings and not as numbers. Because many people, when they get to the point where their life is disabled by their joint pain and the decision is live like this or get a total joint, they get one, they make it through the recovery, and they say, why did I wait so long? So that's the whole spectrum on how I treat arthritis. You did not hear me say the first thing out of my mouth, surgery. There are so many things we can do.
And does that relate any of this, like meniscus tears and all that? Is there any relation to the hormones, or is that wear and tear? Is that something really different?
It's both because, why do we know that arthritis has a rapid increase in women in their 50s? It's because their cartilage matrix is suddenly unprotected. On top of that, they usually gain 30 pounds. On top of that, they're losing muscle mass. On top of that, they feel terrible, so they don't want to go work out anymore. All those things play into loss of our musculoskeletal capacity, if you would.
You talked about exercise a little bit. And so, what's the role of mobility in cognitive function, and what is something you call sedentary death syndrome?
I wish I had made up that term. So we'll start with sedentary death, and then we'll go to my study and studies of many other people on exercise and cognitive function. Sedentary death syndrome are the 33 chronic diseases that we die from, the first of which is cardiovascular disease, stroke, heart attack, diabetes, metabolic disease. They are all positively impacted by moving our body. There is no shred of doubt that exercise, mobility, I use those words synonymously, is the most powerful force for maintaining health and longevity that we have easy access to. Listen, people, we have known how to walk since we were 1 year old. It takes no new skill. It takes doing it. So that is sedentary death syndrome, the 33 chronic diseases that are directly modified by mobility and activity that we die from. For me, it's a very hopeful message. Oh my gosh, we can control the 33 chronic diseases that are going to kill us by getting up off the couch. Yes, we can. Many years ago, in the beginning of my career at the University of Pittsburgh, my group wanted to answer the question, is the decline we see inevitable, or is the decline we see in all aspects in our lives due to sedentary living? So we started doing a series of studies, a muscle study, 2 bone studies, stem cell studies, all of which prove that mobility is the key to longevity. But we wanted to see, and we're some of the first groups to do it, the connection between mobility and cognitive function. Now it's very commonly known, but at the time we were one of the first groups to do it, and we showed that chronic mobility in recreational athletes, not pro athletes, recreational people like you and me, preserved 3 of the 5 executive functions of our brain. And so that was the beginning of now a huge body of research that shows that what our muscles and bones do affects our brain. Let's take bones, for instance. A cell in our bone called the osteoblast, it's the building part of our bone, secretes a hormone called osteocalcin. People think that bones are just quietly hanging around supporting our muscles. Well, they do that, but bones are master communicators. Why wouldn't they be producing hormones? They're from the top of our head to the bottom of our toes. It makes sense from a nature and a creation standpoint to put information where the bone is. Osteoblasts secrete this hormone called osteocalcin in response to exercise. One of the roles of osteocalcin is to go to the brain and help create neurotransmitters for cognitive function.
That's incredible.
I know. Osteocalcin also works in the pancreas and in the muscle for glucose stability. If you're a man, it goes to your testicles and helps your Leydig cells make testosterone. That's only 4 of the multiple things that bone as an endocrine organ does. So we just think bones are silently hanging out, supporting our quivering mass of muscle. But what they are is master communicators in our bodies.
That's almost revolutionary too.
It is. Yes.
It's like you're starting a revolution over here.
I hope so. I'm glad you're helping me spread the word.
Because that is really important information. And then that goes into physical fitness, but social fitness, how I can be more confident. That's amazing. Just incredible. This discussion just has touched on so many different things that are so important. Is there something that you want to talk about that we didn't talk about yet?
The first thing I'm going to say is going to sound a little sad, but the hope I give you at the end is why I'm making the point. I am a practicing orthopedic surgeon. When I am called on call to the bedside of a woman in her 70s and 80s who has fallen and broken her hip, This is what I see repetitively. There she is laying in the bed in excruciating pain. Broken bones are excruciating. She's in that rumpled up old blue gown, laying in a heap, right? Because you slip down in these beds. So she's in pain from a fracture that could have been prevented. We could prevent osteoporosis, people. It could have been prevented. She is often incontinent, laying in her own urine because we did not prevent the gynecourinary syndrome of menopause. We can prevent that. She has often developed so much heart disease that her heart is too bad for the medical doctors to clear her for 45 minutes of surgery that I need. They're like, how fast can you go? I'm like, I need 45 minutes. Her heart is too bad. We could prevent heart disease. She is often has a titch of dementia, either because she's so sick and the stress of it makes her not herself, or she has frank Alzheimer's. That is the state of frailty that I see every day. At least 3 out of the 4, I am telling you, are preventable. So I am a little tired of being on the backside of health. We need to step away from disease care and focus on the prevention that was in our grasp, because we know that the things that are killing us can be prevented. And it's not just the doctor's responsibility, ladies and gentlemen. We are not the victims of the passage of time. We can pivot, no matter what age or skill level we're in, to harness the power of mobility. Make the decision about taking hormones, eating a diet that does not make our body a trash compactor. We can take these things and go from feeling like the victim of the passage of time to taking control and building a body and brain that are unbreakable. That is my hope. That is the passion that drives me to come on podcasts like yours to say we can be healthy, vital, active, joyful long into the foreseeable future if we pivot and take control like we have.
Like you said, there's so much we can do, which is so hopeful and exciting. To become stronger in all kinds of ways.
Absolutely.
Thank you.
Thank you, Vonda, for joining us.
My pleasure. Thank you.
Thank you for joining us on Health Gig. We loved having you with us. We hope you'll tune in again next week. In the meantime, be sure to like and subscribe to this podcast and follow us on healthgigpod.com. I'm Tricia.
And I'm Doro.
Be well.